Bismillahirrahmanirrahim. Now, my dear fellows and students and colleagues and those who are appearing in the undergraduate or postgraduate examinations in outside or inside the country, specifically speaking the fellowship examination, or rather in the examination where the research paper or research is needed. This is the session which I want to discuss with those people who are interested in research work. Now this is the genus Clostridium. I am discussing nowadays about the gram-positive bacillus Clostridium. And there are many species, more than 100 species, 110, 120 species associated with them. There's Clostridium tetanus, Clostridium botulism, Clostridium perfringens, and others as well, Novae, etc. Not important, although the more popular is the next one, and that is Clostridium difficile. This is the part 4 of my series of lecture on Clostridium. I am Professor S. Eliezer. I am Senior Visiting Professor of Medicine, JSUMU. Before foregoing on this difficult organism, look the name of it, Clostridium difficile, I-C-L-E, difficile. When I was doing my fellowship examination, we need what is called a research paper, or what we call as a manuscript, or we call as dissertation. Dissertation is the type of the research you do under supervisor, and you elaborate it, as a research paper. You want to submit it for the MD examination, MPhil examination, or PhD examination. Now this is a paper for this is called dissertation. It's important in passing or further proceeding with the fellowship examinations, where you are doing in internal medicine or surgical and allied and so on. Many of the persons, more than 80 to 90% of the candidates, they took help from the persons who are professionals, and they make their papers. Remember, if you do not write it down by yourself, you will be lacking in your life, missing. Although you have written a paper, that's all. It means nothing. It means very important. Very important. Now this is actually there are, for this means difficult. Difficult to detect, or difficult in the sense for the pathogenesis mechanism of this organism to understand, difficult in this sense, or difficult to culture, or difficult to manage. The difficile. There are a lot of research papers was going on since 1995 and 96. In 90s, it was recognized as an organism which is related with the pathogenicity. Before this, it is regarded as the same one. I've said the Campylobacter and Helicobacter as commensals, and it is part of the bacteria which are known as coliform bacteria. Is one of them at that time. So a lot of papers have been written. It is more than 300 or 400 papers have been written on this subject. I am a clinician, therefore I have written a dissertation which is clinically oriented. Now it is in 2016, where this is the organization which reported and a journal is published, is more virulent than ever. Means that before it was not regarded so much virulent organism. The most important outcome because of it is the pseudomembranous colitis. Severe type of, very severe type of colitis. Which leads to pseudomembranous colitis and the hemorrhage and rupture of the colon. So you need to go for the surgery, urgent surgery, emergency surgery. And you have to cut it down before the patient will die. And you have to do the end-to-end anastomosis, etc., to save this patient with the full-blown septicemic therapy. I have written there in 2012. Actually, it is written in 2012. It was actually written in 1998. It means that I am senior person after the evolving Clostridium difficile. In 1996, I have started to collect the patients. Though it was a dissertation, then it was made as an article to be published in the College of Physician and Surgeon. Now, CPSP journal is the recognized journal in the, as far as PMDC is concerned, as well as the Health Commission is concerned. The higher education and other organizations accepted this paper as #1 journal in Pakistan, including the journal published by the Ayub Medical College or journal published by the Pakistan Medical Association. Now this is the one which was following, which will be followed in Europe and in America also. So I submitted this article after I have passed it in 2002. I have passed FCPS examination, very, very difficult way. And that is another story I don't want to discuss. As assistant professor of medicine in 2012, I have written this paper. Rewrite again the dissertation into the paper. It is my student, he was a student, is Professor Chaudhary. If he is listening, he is #2 writer of this paper, associated writer of this paper. He was my student of final year MBBS from Lahore International Medical College. And he was the person who was graduated in computer science already from United States. He is Pakistani, but he is American by birth, and his mother was American. His father is from Punjab, Pakistan. Professor Faiz Chaudhary is the person who assisted me in the rewriting of this paper. This paper, okay, I have written this paper, is published in the CPSP journal. It's an honor, of course, a person to write an article published without any objection. And it was followed by the many organizations in the United States and Europe. Because I have actually dig the grave of this knowledge, which was already buried inside the earth as a grave. You know what is exhumation? Exhumation is the post-mortem examination after you have buried the body. So it is exhumation actually. It's a very difficult point this is. That it was proved that the previous research was not considered correct. I challenged them. I said that in my country, because the facilities are very difficult to achieve. You know, to write a paper in the United States and in America, or some parts of the Southeast Asia, they will give you money. They will back up you with money. In our country, we will give money to the journals. This is the hallmark. The writing and the publication and other works need money. Or you are doing the research, you will do the investigations. So you will spend money on this. This is the hallmark of it in our country. That's why research is not very, very effective, and they are not accepted by many countries. Because the false numbers will be shown, and investigation are not properly done, and statistics, the medical statistics should not be done here. It will not be done, sorry. And that is why they do not like papers written by any person from Pakistan, and then afterwards the other developing countries. So this journal was followed in America, and many comments have been given on this article. Why you have written this article when the research proved? So I answered them on email. The objective of the abstract I am reading to you the abstract of this article. To study the frequency of the Clostridium difficile in post-antibiotic diarrheal in patients admitted in the medical ward of the secondary care hospital. Now, the secondary care hospital means it is the hospital which is at that time in 2008 to 9, I have inducted the patient and studied there in Sindh Government Hospital, Liaquatabad. Study design is observational study, place and duration of study, Sindh Government Hospital, Liaquatabad, Karachi, from 2002 to May 2009. Methodology: the adults of either gender was received antibiotics after admission and subsequently had watery stool at least 2 days after the admission was detected. It means it is the incubation period, at least 2 days. The exclusion criteria were past history of the inflammatory bowel disease or any type of the malabsorption state, and those who did not show any WBC in the stools. All variables of these patients along with the clinical finding, type of the antibiotic received, and number of the stool motions per day were recorded. 3 samples of the stools were sent for the detailed reports to analyze the number of the leukocytes per high field, and culture has been done on cycloserine, cefotaxime, fructose agar, CCFA. The popular, it was a media at that time. All findings were entered into the analyzed by the SPSS 16 for statistical analysis. Now, results were out of 473 patients who received antibiotics for any reason. 191 patients, about 42.38% developed diarrhea, a large number of patients. The mean age was 45.6 plus minus 17.3 years, and male to female ratio was 1.85:1. Now, males are more affected because they admitted in the wards. Usually female, they don't do for the admission. The severity of the disease, if there is severity of disease, they admit, otherwise they will not like to admit their patients in our country. The average number of the stools passed per day was 4.84 plus minus 1.24, it means about 3 to 5, and all patients showed leukocyte in the stool sample with a mean count. Now, this is a very important point. 6.67 plus minus 0.89, it means that about 5 to 7 per high power field. More than 5 is significant in this research. The stool culture on the CCFA was positive for 57 patients. That is, only 29.18% were positive for this, while 134 patients, 70.15 were stool culture negative, as well as negative for the evidence of any parasites. These samples were labeled benign antibiotic-associated diarrhea, BAD, BART. This is the terminology I used here. Benign antibiotic-associated diarrhea. Ampicillin and amoxicillin with clavulanic acid were the most implicated antibiotic in my study, and others also. Tetracyclines are concerned, and macrolides. And the safest drug which I used, I have seen in these patients, were the quinolones. Although in their research in America, the second most important drug indicated for the antibiotic-associated diarrhea was quinolones. But in my study, it is the last one. In my study, the first one is the ampicillin, amoxicillin, followed by the other one, the macrolide, the lincomycin, the fusidic acid, and so on. In settings with the limited resources, this is a very important point, because I have done my own resources. Use of the specific culture media, the CCFFA, provided by a clinical microbiologist who was interested to do it and help me in a low cost to provide me the result of this culture, proves to be highly cost effective, because he has charged me only 500 or 700 rupees for this per patient, and is sensitive for this diagnosis. Again, in my research, the macrolides and quinolones are the safest agents to prescribe in this context. Although argument has been done with me and in America, okay, no, it is not possible. In America, it is possible. In our settings, it is possible. In your setting, the penicillins are more implicated in this. In our setting, the quinolones and the macrolides are safest. In your study, the quinolones and macrolides are the culprit drugs in their country. This is my research. What is observed is observed. So they recognized, actually, they accepted my argument, and they published in this abstract in their research, research gate or research something like this in organization in America. So this is another organization, MMWR. Incident, death, and access healthcare costs are historic high. In America, it is plus minus $1 billion per year. Between $1 to $3 billion per year. 3-time increase in the decades now, 500,000 infections and 29,000 deaths per year. More deaths than even MRS, that is methicillin-resistant Staphylococcus aureus infections. It is the number one cause of the increased overuse of antibiotics. It is number two cause, appearance of more virulent Clostridium difficile strain associated with the risk of the greater mortality. It is number third cause, increased relapse rate. 20% of the cases have at least one relapse, difficult to treat. Very difficult, relapsing rate are more. Number four is the overdiagnosis. It means diagnosis is because of some other issues. You diagnose as on the clinical ground with something else, the false positive of this disease. Overdiagnosis. Because the pseudomonas colitis or the antibiotic-associated diarrhea can be caused by the clinical scenario can be achieved by other drugs, other diseases as well. Overdiagnosis. This is the problem. But asanak, if they have taken this, the antibiotics and the diarrhea starts, it means that it is related with this. Whatever it is, you are taking, even ibuprofen can cause it. Ibuprofen. I've seen diarrhea associated with the paroxicam. Even these are not antibiotics, these are anti-inflammatory agents. The chemical irritation produced by them can cause the diarrhea. It is possible. So this is the overdiagnosis. Now, Clostridium difficile is anaerobic. As Clostridium is anaerobic, spore-forming bacillus. Clostridium difficile associated diarrhea, CDAD, this terminology should be remembered. Now, Clostridium difficile associated diarrhea may be of mild, it may be moderate, it may be severe, it may be very severe, like pseudomembranous colitis or toxic mass of colon, leading to sepsis and death. This is the fourth type in my studies. The fecal oral transmission through contaminated environment in the hands of the healthcare personnel, they are important. Antimicrobial exposure is a major risk factor for the disease, although this part must be supplemented with this. This is the major cause. It is supplemental cause. The acquisition and the growth of the clostridium difficile. Growth is difficile. And suppression of the normal flow of the colon and clindamycin, penicillins, and cephalosporins in their studies in America. These are the culprit drugs. How many of you use clindamycin? It is very, very commonly used in pediatrics world. Lincomycins, that is Diarrhoea C, very common drug, very, very effective agent against the staphylococcus and streptococcus, gram-positive coccus. The spectrum of the difficile infection is asymptomatic carriage may be there, which is asymptomatic carrier. It is a part of the coliform bacteria, I already said that. Antibiotic, it can cause antibiotic-associated diarrhea, antibiotic-associated colitis without pseudomembranes, severe type of the colitis, and it may cause the fulminant colitis with ARIA, that is called toxic megacolon, high risk spontaneous rupture. Let's see now how it happens. Now this is the diagram of this. Actually, the coliform bacteria which are present in the newborn, they are gradually the bacterial growths are going on in the neonates after the birth and in the infant period. You notice that their color of the stools usually in the newborn period are greenish or greenish yellow in color, and they become normal in about 3 to 6 months. When all the coliform bacteria, they are cultivated. Why you need the coliform bacteria? Why you need? It is a part, very important defensive part. Number one, it will definitely, they are commensals, yes, of course, but they are very important barriers against the infection, because if any bacteria entered into any serotype of that genus is appear in the colon, there will be definitely a defense produced by the coliform bacteria. Secondly, they secrete some of the vitamin B complex, and they also secrete vitamin K by Escherichia coli. So they provide the vitamins also. So these bacteria are important. I will say they are important for the normal function of the GI tract. If they are suppressed by giving antibiotics or by anything, then other commensals which are novel agents like Clostridium difficile will cultivate more now, and it will invade the mucosa and it will cause colitis. This is the pathogens. Supplemented by the hand washing, but poor and unhygienic fecal-oral transmission, that is possibility. There are supplemental problems. Actually, the major problem is that you have actually modified the environment of the coliform bacteria and allowed the novel agents or the agents which are not commensal in that area, the other area they are commensal, they come in and cultivate more and invade the colon and cause this condition. Now this is a simple pathogenesis. At one time in 1975, my great father of medicine, Professor Hassan, always gave the vitamin B complex with antibiotics. He said the normal flora will be disturbed and vitamin supplementation are not enough, because the endogenous production of the vitamin which are producing by the bacteria lost. So you should give multivitamin or B complex to these patients. At that time, Davidson, in 1970s, Davidson, it is written also there. The vitamin B should be given with antibiotics. Now, asymptomatic clostridium difficile carriers, yes, you or maybe I am also a carrier. 60% of stool carriers in my studies also had it on their skin. It is saprophytes and their surrounding environments. A spore-forming organism it is. Therefore, it is present in the environment. Spores on the skin of these carriers were easily transferred to the others. And they multiply inside it because you are giving, if they are suppressing the defense mechanism of the coliform bacteria, they will cultivate in the colon. Non-poopers mean that they are constipated type of person, an important source and potential infection to the others. Everyone should watch with the soap and water. Because if it's not related with the feces, then the source of infection is somewhere else, external environment. Before you eat anything, please wash your hand properly with the soap and water. Because if you give the lethal dose of the Clostridium difficile to the colon, it will cultivate there and will produce the disease without any antibiotic. So it is called Clostridium difficile associated diarrhea. It is also known as the benign non-antibiotic diarrhea. Antibiotic is not given, but the diarrhea is severe, and cultures and other means of the detection prove that it is the Clostridium difficile which is responsible. Now this is what I have said, that they are entering and they are reaching the colon where the coliform bacteria are flourishing. They cultivate here more and more, they enter here, destructions occur of these cells of the epithelium. They enter, some of them enter into the blood and cause the bacteremia, then septicemia, then the cysts, then pyemia, then hemorrhages, and then ultimately the septic shock. Or they destroy it here, an ulcer is made, a membrane was formed, in thin membrane, it is in this area, that is called pseudomembranous. Actually, it is not actually membrane. It looks like membrane, all the mucus is collected as a plate, and all is destroyed. And your defense is only this membrane. If it is gone, there is definitely a rupture and hemorrhage. That is called pseudomembranous colitis. It usually occurs in the transverse colon. And look, this bacterial is flourishing in this area. There is a membranous formation occur, collections. Now here is a normal one. You cut down here, here it is open here. In the transverse colon, you are seeing these are the structures normally of the colon. This is the area which is affected badly, and the collection is of just like a membrane. Here it is adherent. Factors underlying the upset of the clostridium difficile disease, that increasing virulence strains are producing, because as the time goes they are producing strains. Mutation occurs. Increasing resistance to the strain to the antibiotics. Next important point. Or increasing older compromised population, immunosuppressant, more antibiotic exposure, they are taking over-the-counter antibiotics, suppressing the normal flora. It will lead to the Clostridium difficile associated diarrhea, and it is alcoholic based hand rubs. They said there are a possibility that they may be a supplemental problem associated with this. This is another research. Proper hand washing should be done with the soap and water, not alcohol based. This is a NAP study that the difficult Clostridium difficile strain, nasty super bug, they call it. Now seen throughout the Nevada in USA, a challenging position in Nevada, USA. In this case, there is approximately half of the cases In Nevada, USA, they are NAP1 positive. That is, it is positive according to this study which is done for the Clostridium strain. Resistant to common antibiotics overused in the hospital, particularly fluoroquinolone, in their population, not us. A genetic mutation allows 10 to 20 times more toxin A and B. They are exotoxins which are secreted by the Clostridium difficile. Plus, it has its own unique binary toxin, and that is toxin C, have also been described. More likely to progress to fulminant disease and the death, and increase rate of the spore termination to active disease, increase the likelihood of the relapse. After the event, even you have chances that the relapse and remit can occur, just like inflammatory bowel disease. In your micro lab, there's a PCR, they are already testing the NAP1, this is the antigen, but you may need to request results. It is not available in Pakistan. Now, difficult diagnosis. The problem is that in our country, we cannot do the toxins levels in the stools, toxin A or B, because they are very, very costly procedures. It costs more than 10,000 rupees for a stool for the detection of toxin A or B. It may be more than that. How can a poor person can tolerate? Secondly, even the culture in some labs, they are only culturing in the CCFA. They are charging 2,000, 3,000 rupees. Although it is difficult again for a poor person. They said in the America that a direct culture not used because slow turnaround time, dollars are wasted. But in our settings, the culture is important. Because in my study, I have spent 700 to 800 rupees by me or by my friends to see the culture positive or negative. Now, Clostridium, there is ELISA in the Clostridium difficile producing toxin that detect the toxin A and toxin B. They detect the toxin PCR because some of the proteins they are generated specifically by the Clostridium difficile, but misses some cases. They are 70% sensitive. Sensitivity is 70% only. Is that important? That is important because 30% will not be diagnosed by the ELISA. This is the direct culture. It is more helpful rather than this to me. Specifically speaking, the PCR is concerned. ELISA and PCR. PCR means that it is definitely disease is present, whether it is benign, whether it is mild, it is moderate or it is severe, 100% sensitive, but does not differentiate between asymptomatic carriers and toxin producers. You cannot diagnose this condition on the spot. Do not order as a test of cure. It is not the 100% perfect cure if you are PCR negative. No, it doesn't mean. It means that the careful patient selection is vital. Up to 50% of tested patients that don't have a significant diarrhea. Significant diarrhea means 1 stool or 2 loose motions. Up to 40% are a laxative regime when tested. 40% were using laxative at the time of the admission, but they didn't, because you have not asked, they didn't answer it. The PCR test may be 100% sensitive, but only 45% positive predictive value of this diarrhea. So its test is not so much valuable for us. There is no difference in the length of the diarrhea or mortality in the toxin or PCR or toxin PCR patients. The clinical conditions of the patient is important. In my opinion, negative consequences of overeating the Clostridium difficile associated diarrhea is the contact precaution adversely affect the patient anxiety, depression, isolation. Because you have to isolate now. It is nosocomial now. The recessive unnecessary antibiotic that can be paradoxically increase of actual diarrhea and select the other conditions, etc. high-risk conditions, expense of isolation, need for single room. Adversely affect hospital infection, including incident of nosocomial infection, enlisted this organism. Again, you are building a hill of infection in the hospital. Human beings are ecosystem, not just an individual. Ecosystem. They detect it. But a collaborative effort between the commensal bacteria and the host. Their relationship is important. The ecosystems. They detect the problem which is going on. The God Almighty, Allah Almighty has done very unique thing in your body. You can't understand it even. So the diarrhea is a mild diarrhea, it may be moderate diarrhea, it may be severe diarrhea. You can read my paper. It is available on the Google. You can read it. I don't want to discuss. And the pseudomonas colitis. Which antibiotics prone to develop, which are not prone to develop, which are safe to give. I have already said the safest antibiotic which in my studies are fluoroquinolones. Secondly, the macrolides. They are least involved. But according to the American researchers, they are the indicators. Now, important thing is that how you manage it. In the mild cases, no management is needed. In moderate cases, you will give the metronidazole by mouth, if it is possible. Otherwise, intravenous. By mouth is effective. If it is severe or very severe, or I will say severe first. Now, vancomycin orally will be given in my study. And they have accepted it, yes, it is. If it is very severe, then give the intravenous metronidazole along with the intravenous vancomycin to this patient. And also for the other gram-negative bacteria, add with the gentamicin, etc. to save this patient from the septicemia. If there is another type of the diarrhea associated with Clostridium difficile, is the recurrent diarrhea, carriers, diarrhea, chronic diarrhea, means that relapse remission occurs. In those cases, there are two type of things you can do. Do not give these metronidazole or vancomycin repeatedly. No. Otherwise, you give the what is called the biotics. And these probiotics are, for example, the Saccharomyces species or other Saccharomyces can be used, unclogged sachet, or the water which are present on the surface of the yogurt that can be used in mild type of diarrhea, which is recurrent diarrhea after this. As a last resort, you do the duodenal infusion of the duodenal feces for recurrent Clostridium difficile. Capsules are there. Look, these capsules. These are capsules invaded with the feces. It is a new advancement in this. Recurrent diarrhea associated with the Clostridium difficile. Secondly, the beagle is a dog. It sniff anything specifically. First of all, it is trained that in hospital areas if this growth is present or not. Now, this is a beagle test, sniff test. This dog is very, very intelligent animal of the world. It can differentiate between the Clostridium difficile to the other bacteria, for example, Clostridium perfringens. Even if Clostridium perfringens is there, it will be trained for the Clostridium perfringens. The other dog was trained for the Clostridium difficile. Specifically, they will detect this area, they will bark at this area. This is the area where the possibility of the culture is there, of this. And they detect from this area, for example, where I'm marking, by the sniff test of the dog, and they detect it very correctly. And this is a very, very important thing. as far as the spread of the infection in the hospital are concerned. The bigger sniff test. We have a very recent example and use of the animals, use of the Almighty Allah who has created this animal and detected it to you that the cultivation of the bacteria of this Clostridium difficile is there, pointing out. You cannot do it. This dog can do it. Sniff test. As it is sniffing in, for the illicit drugs you are carrying in the aeroplanes, they detect it. They are trained for it. And this dog is trained for the Clostridium difficile. Other dog was trained for the Clostridium perfringens. Another dog was trained from the Clostridium, for example, botulism. So they sniff it and they detect it. That is very unique thing. At one time, we are doing for the pseudomonas colitis, permanent colitis, in addition to the high antibiotic, vancomycin, metronidazole, or Genta, etc., to save the patient from septicemic shock, they resected and end-to-end colon anastomosis was done. Remember, this is the colon nearby is also affected. We don't know which part is actually the last part to cut. So the double barrel ileostomy preserves colon much lower mortality. This is total colectomy because they have to do the colectomy. All transfer colon will be gone. All ascending colon will be gone. Here, no colon will be gone, but rather they form the double barrel ileostomy. Preserve colon much lower mortality. They just block it and they switch the ileum to this area to directly go the material into that part which is safe part now. And this is the blind loop which is behind it. This is the new one, surgical methodology they have used. Very, very effective. Although this topic is very big topic for me, I can talk for more than 2 to 3 hours on this subject. I challenge the United States workers because my work is not based on their PCR and the detection of toxin. I detected the Clostridium difficile on the basis of the clinical symptomatology. Number 1. Number 2, the detection of the WBC inside in the stool, and number 3, in the culture. And this was buried actually before this paper. That they are not very important parameter for detection. I said that they are parameter very important in our country because we cannot afford PCR, we cannot afford the ELISA, etc., etc., etc. I thank you that you have listened to it. I don't know whether you like it or not. Wa ma alayna illa al-balagh. Assalamu alaikum wa rahmatullahi wa barakatuh.